with like bright red blood per rectum, the GI symptoms. So this was the first initial presentation. I mean, there was no known liver mass at the time, but this was the initial CT that we got, and I read the CT. And I thought there were abnormalities in the bowel. Here, there's some semicolon hyperemia, a little bit there too. And there's stranding here. And then there's some lymphadenopathy. Let's see. Oh, there's a bone island. So I sort of gave this like non-specific DDX. Nothing in the liver. Where is the lymphadenopathy? Oh, there's more bowel. So it's sort of like scattered multifocal bowel abnormalities, a little bit of lymphadenopathy. And then the patient got, new patient, this follow-up non-con CT. And the time interval was like within a month. So this was 10:30, and the one before that was, oh God, I don't know what it was before, but it wasn't that like large of a time interval. But so there's nothing in the liver. Let me see, what else? I don't think we saw anything else significant. They said it was non-con, so it was sort of hard to appreciate the bowel abnormalities that we saw in the initial scan. Then they got this MRI, and there was a liver mass. So by this time, they found out that the patient had aplastic anemia, was neutropenic. They were like working up this patient, didn't know what was going on. So they got this MRI, and then we saw this liver mass. The liver is also abnormal. It's very low signal intensity compared to the paraspinous muscle. Which can be seen with iron deposition, for example. The spleen is very small, but it's right here. It also has very low signal intensity compared to the adjacent muscle. So they called this liver mass. They gave a differential diagnosis. It was done without non-contrast. So, but I can show you the pre's in and a post phase. There's no fat in it. It's new compared to that. Initials, and then I came, and when I was on service, I saw they recommended EOVIST MRI. So they got an EOVIST MRI, which is what I read. So here it is again. We see it, and then on the delayed phase, maybe I shouldn't jump to it, but let's see here. If you want to see the rest of it, I sort of here it doesn't. Here's the, where's the pre? Here's a pre, so maybe there's a little bit of enhancement here. And then where's the EOVIST phase? So on the EOVIST phase, it looked like this. I don't know. There's a little bit of uptake. But remember, the background liver is abnormal because of the T2 dark signal. What do you guys think? They got a biopsy after this, so I'll tell you what it said. So I said there's EOVIST uptake, which is kind of weird. Sorry, go ahead. Okay. Nice, okay. Neither could I, yeah. So they, IR like called me. He's like, what do you think? Like, do I have to biopsy this because the patient's thrombocytopenic and I don't want this patient to bleed, and I don't, want to avoid biopsy at all costs. I had recommended follow-up imaging in 3 months, but they wanted to treat the patient's aplastic anemia with meds, and they needed to know if this was something that warranted treatment or anything like that. So I sort of like I shrugged my shoulder and I said, I don't have a high level of confidence. So they went ahead and biopsied it. And the biopsy showed amyloid. Here. Is it? No, this is the left liver mass. Where's the regular liver mass? Here. No. Oh my gosh. I'm sorry, it's out of order. Oh, here it is. Yes. Um, so they said there was no HCC. Um, and then there's moderate hemosiderosis, which explains the background low T2 signal intensity. And then they sent it off for like special studies. And they said there was amyloid deposition. They sent it off for IgG4, and it was negative. They saw IgG, but less than 10% staying for IgG4, so they said that it's probably not IgG4. So I was sort of like, I was like, well, how do you like tie like your fellow? Like, how do you tie in all the bowel stuff with the liver stuff? I mean, I was so confused. So then I like started looking up amyloid stuff. So normally amyloid deposition, you have more of like a heterogeneous appearance of the liver. There's like some thickening around the portal tracts, and I guess and these are seen in patients with inflammatory diseases, and they can have low signal on T2 signal in the spleen, like we saw in our patients. The spleen was small, but it was low signal intensity from amyloid. So they said that's one mimicker of iron deposition is amyloid deposition. And then there's another case that I saw. It's this patient with systemic amyloid, and I didn't realize this, but they can have a combination of liver and bowel findings. So they get in this patient with systemic amyloid, they had diffuse low signal liver and spleen signal intensity, which is what we have in our patient. And there's wall thickening of the small intestines here. These are all non-con, so we can't really see the mucosal hyperemia. And then there was one case report that I saw where there was a hepatic mass-like amyloid. It's usually diffuse heterogeneous, but here this is a pathology-proven amyloidoma, I guess, of the liver. And so I was thinking, like, oh, could this patient have like more like this patient, like a systemic amyloidosis, manifesting with these like liver and bowel disease. I should have looked it up. I don't know if amyloid causes aplastic anemia, like a marrow replacing process, to explain the aplastic anemia, but that was as much as I can come up with. What do you guys think?
I just briefly looked it up, and I didn't see that they're frequently related.
Okay.
I saw like case reports of people who had like lung cancer with aplastic anemia and amyloid. I think you can get amyloid deposition like from a lot of different causes.
Mm-hmm.
And it seems to me like basically like a diagnosis solution. Like you have to biopsy it. You can't be specific about it.
On imaging.